about my interactions with him. What I'm passionate most about is being a member of ITI. Some of you may know ITI is all about sharing with colleagues and learning from colleagues. As you can see in the pictures above, this is what my friends and I who do implant dentistry in Kenya are involved in. Small groups, we have meetings and chats from time to time, and we learn a lot from each other. And I'll encourage you in Uganda to also look into the same. In fact, if you look at the bottom pictures there, you'll see that there are actually scholarships, in the ITI. I'm aware some of you are applying, and I'll be happy to send in a recommendation for whoever may be interested in. There's also a curriculum that you can go through to improve your implant dentistry. And to today's topic, we're talking about management of bone deficiencies in implant dentistry. And we will do a review of the fundamentals. Now, this is a very broad topic. And for that reason, it's very difficult to cover everything that there will be in bone management within 1 hour. I shall nevertheless attempt to highlight the most important aspects. Now, majorly, we shall go through management of horizontal bone deficiencies as they are more common. Vertical augmentation is a bit more technical and will require a separate session where we can have detailed conversations. All pictures and x-rays that will be shown in this presentation are my own work. However, where non-original images are used, acknowledgements will be made. This presentation is purely based on the well-established scientific and clinical principles of guided bone regeneration. So I will attempt to stick to science, and I believe through that you will pick something out of it. Now, by the end of this presentation, I hope that we shall have appreciated the need for pre-surgical planning. We shall also appreciate the rationale behind guided bone regeneration. And we shall have understood biomaterial selection criteria, because there are so many materials in the market. How do you choose which material to use? In implant dentistry, our interest is to provide the patient with a long-lasting restoration that affords them comfort, function, and aesthetics. And we are talking about long-term. So whether you're doing a complex case, as you see the all-on-4 case there, or indeed a straightforward case, a single implant case, the goal remains the same. Now, when you're placing implants, we want to be restorative driven. We want to have the implant in the correct 3-dimensional, 3D implant position. Why is that important? For restoration. It's important to ensure that it's correctly placed. And this is now well enumerated under the ITI guidelines. If you join ITI, you will see we have treatment guides, and you'll learn a lot from that. In fact, with surgical guides now, you can even achieve that position better. When you're still placing, it's important that you attain good primary stability, because osseointegration is dependent on achieving good primary stability. And when you place your implant, you have at least an insertion torque. You can at least use that as a guide of, an indication of having attained primary stability. Or you can go digital and use an ISQ machine to determine that device there helps you determine the stability. Now, those two important factors, correct 3D position and attaining good primary stability, are dependent on availability of adequate volume of healthy bone. It is now a fact that if you want a long-term solution, you need to ensure that your implant is surrounded by adequate volume of bone, at least 2 millimeters all around. This is where we wish to be, treating patients who come from the land of bone. But let's be real. Many times, this is what we are presented with. Notice the ditching on the back. That flattening there can preclude positioning an implant as you would wish. If you are to follow the bone, then you will not position the implant where it should be. And that forms the basis of our discussion today. What do we do with that defect? Now, closer home, we did a study back in 2018, and what we were looking for is whether we actually have buccal bone on upper anterior teeth, canine to canine. We looked at about 184 cone beam CTs. Out of those, we looked at 1,104 teeth. Remember, these were healthy individuals. We wanted to find out if we were to remove these teeth and immediately do an implant. We are told we need to have 2 millimeters of bone buccally. Do we already have? And this is what we found, that in 63% of the cone beam CTs we looked at, the 1,104 teeth, 63% of them had thin bone. And by thin bone, we meant 1 millimeter or less. And only 12% had actually what we would desire, a thick buccal bone, greater than 1 millimeter. We also found out that at least a quarter of the cases actually had no buccal bone, like you can see in that section of a cone beam CT. Overall, we found that 80% of the cases we looked at actually required a bone grafting procedure if you were to ensure that you have buccal bone surrounding your implant. Now, that means that cone beam CTs will actually be a very good tool for you to evaluate and plan in advance, anticipate problems. Look at those two. You'll be lucky if you did not do a cone beam CT, placed an implant, and yes, you end up with at least bone surrounding your implant. But it is also a possibility that you can actually completely miss it. And Dr. Tom Tiable once told me, without a cone beam CT, you're guessing. I now agree. Now, let's look at, therefore, what do we do with those deficiencies? Let's look at bone augmentation. When we talk about bone augmentation, our intention here is to have bone where there is a defect, but that bone needs to be covered with a membrane. And this discussion that we're going to have from here will be about why use a bone, why use a membrane, and how do you combine the two. Like I said, this talk is premised on this well-established principle of guided bone regeneration. Now, Danny Buza and colleagues are actually now about to release this book of the 30 years of guided bone regeneration. There's already one on the 20 years of guided bone regeneration. So this is a very well-established principle. And what I'll do, I will highlight and show you what we do at our practice. So what's the goal of guided bone regeneration? The aim here is to attain high predictability Yeah, you want to almost tell the patient, this is what we shall attain. When you're doing that, you want to ensure that it is at a low risk of complications. It should also be cost-friendly to the patients. Now, I want to use an analogy of why bone, why membrane. Now, generally speaking, and from our preclinical medicine, we remember, bone is a slow-growing tissue. Yet the tissues above it, yeah, the soft tissues above it are fast-growing. Epithelium and fibroblasts are fast-growing. Since we want to regenerate bone, it means then we must seclude an area and only ensure that only bone cells grow in that area. So let's use this example of a tent, whereby membrane, in this case, is analogous to the canvas of your tent, and bone is the tent pole. In other words, it is a membrane that we use to seclude an area where we only want bone cells to populate. We want bone and blood vessels to populate that area and block out the fast-growing tissues, which will be fibroblast and epithelium. So once you have these in mind, then our discussion from this point will be better. So there are some two terms that I find clinicians commonly interchanging, and I find it a misnomer. There is guided tissue regeneration and there is guided bone regeneration. Now, guided tissue regeneration is mainly done around the teeth because the intention is to regenerate supporting periodontal apparatus. Remember, this includes the alveolar bone, the PDL, and cementum. Yet, in guided bone regeneration, our only intention is to regenerate bone. So it's important that you distinguish guided tissue regeneration from guided bone regeneration. Bob Schenk and colleagues conducted several studies. One of them is a 1994 study where they wanted to find out, between bone and membrane, which is more important. Can you do without the other? And what they found out, this was a study in dogs, is that when you use a membrane, you attain better regenerative outcomes. Look at the picture on the left and the picture on the right. On the right, no membrane. On the left, there is a membrane. So a membrane is critical if you are to attain the volume of bone you wish to regenerate. At this point, therefore, let's look at the various barrier membranes. They are either resorbable or non-resorbable. In other words, some are degraded by the body. Others you will have to remove. So let's start with the non-resorbable. Traditionally, and I know you've probably all come across this, non-resorbable membranes were mainly made of, titanium meshes. Very good when you need to regenerate a vertical volume that's deficient, and also in extensive horizontal defects. The only drawback of this is that you need a second surgery to remove the membrane after you have regenerated. Sometimes they get exposed prematurely, and when they get exposed, there is many times bacterial colonization, and you could actually end up losing the whole bone that you really needed to regenerate. But companies have found innovative ways of achieving the same. Remember, a membrane is supposed to block out tissues. But when the membrane is not very strong, it is going to be squashed by the tissues, by the by the soft tissues above. And in that way, then you do not regenerate what you wish. So for example, what Straumann has done is they have this innovative non-resorbable membrane made up of high density polytetrafluoroethylene, the EPTFE as we commonly know it. And the beautiful thing about it is that, you can stitch through it, you can fix it using pins. And even at the time of removal, you do not need a very big wound. The re-entry is very small because this material is flexible. You just need a small opening and you can actually pull it through. So that really helps because there are times when, yes, you need to use an unresorbable membrane. In fact, you do not always need to cover it. Even with that exposure there, the newer membranes do not get as infected by bacteria as they used to be with the titanium meshes. And you see, they are impermeable to tissues and also bacteria that may want to grow on the surface. The other thing that makes it easy to remove is that tissues do not grow on it. Unlike the titanium mesh where, through those holes, tissues could grow, and therefore when you're removing it, it's a very messy affair. This, it's easy to retrieve. So those are non-resorbable membranes indicated for vertical bone defect regeneration and also extended horizontal cases where the overlying tissues may actually, compress on the grafted area that you are working on. Let's look at bioresorbable membranes. So you will find that, every company has, various options for even resorbable membranes. For instance, with Straumann, they have the one on the left and the one on the right. Now, the difference between these two is that the one on the left is actually thicker than the one on the right. It will therefore mean in situations where attaining tension-free closure is required, you may then want to choose the one on the right side. Even more importantly, is some resorbable membranes resorb way faster than others. For example, the one on the left resorbs in about 2 to 3 months. It's resorbed. The one on the right takes up to 6 months to resorb. It would therefore mean in a situation where you have a small defect, then you may want to choose a membrane that resorbs earlier. In a case where you want to regenerate over a long duration of time, then you may want to choose the one on the right side. So it's important to internalize those because then selection of materials becomes more informed. Yeah, mainly these materials are made of collagen type 1 and type 3 in different ratios, and therefore the difference in the resorption speed. There is also, for example, this mucoderm, very useful when you want to, to increase the thickness of the tissues, the soft tissues above your bone graft. Because remember what we said, that soft tissue is the issue, but it is the bone that sets the tone. So it's important to have both tissues well taken care of if you are to attain a long-term good outcome. Now, the drawback, however, of resorbable membranes is that they lack mechanical strength, yeah, unlike the non-resorbable membranes. So it's important to bear that in mind. They also tend to get biodegraded very fast. So sometimes if you're not careful, you could actually end up with the membrane resorbing way earlier than your bone. And then, you will be wondering why then, yet I did everything that was advised. Why didn't I achieve what I wanted to achieve? It's important to bear that in mind. Sometimes also some membranes, if they're made of polymers, some of them you end up with foreign body reaction. It's rare, but it's important to know that that happens. Now, This is a picture, rather a series of pictures that are not my own. But what I want to explain here is sometimes you end up with membrane exposure. Now, one of the commonest causes of premature exposure of membranes, in 2-3 days, the patient comes back and tells you, I can see a white thing through my gum. What tends to happen is if you're stitching and you put your stitches too far apart, when the hematoma forms, this wound could all open up. So it's important to ensure that, 2 to 3 millimeters apart would prevent this kind of a situation. However, in the event that happens, it's not the worst thing that can occur. Look at picture 2 and the last picture and notice that even with that exposure, if the patient maintains good oral hygiene, you do not need to go and remove the membrane. As long as they rinse the mouth, with chlorhexidine, and then you put them on a weekly recall. Sometimes you may want to put them on antibiotics, depending on the extent of exposure. And it's important that I mention at this point, the difference between some membranes are said to be cross-linked, others non-cross-linked. Cross-linking really helps to increase the mechanical strength of a membrane and also prolong how long the membrane takes before it's biodegraded. It can both be a good or a bad thing. When they are cross-linked, it takes longer to resolve. It also means when you have a spontaneous exposure, as indicated, then you have a lot to do before the epithelium can actually close that wound. So bear that in mind. You'll actually now find that most clinicians avoid cross-linked membranes. So we are done with membranes. Let's talk about bone material. We have said the primary function of bone is actually to support the overlying membrane, because a membrane, if it's non-resolvable, if it's resolvable, they lack mechanical strength. But look at that bone particle. You notice the many channels. The intention of manufacturers is to give you a bone that is hydrophilic, because remember, we want cells to grow on this. So then those porosities enable new cells to grow in and the blood vessels. Because I know one question that commonly clinicians ask is, what bone particles should I choose? If the particles are so small, it also means that there is not a lot of room for new bone to occupy. If they are huge particles, it also means it's difficult to handle and sometimes to just pack in the defect that you're working on. So it's important to know what kind of a defect you're working on as you choose whichever bone material. So mainly, the functions of bone are: 1, to support the overlying membrane, to act as a scaffold for ingrowth of new bone cells and blood vessels, and also to stimulate the body to generate new bone. We shall see that in some slides. Now, ideally, a good bone substitute material should contain some viable osteoblasts, and that is what we call osteogenicity. We all know osteoblasts are the main cells involved in laying of new bone. Another good property that a bone material should have is that it should be osteoconductive. In other words, it provides a platform, a scaffold for new vessels and the precursor cells to occupy. Another important feature that a good bone substitute should have is it should be osteoinductive. In other words, it should be able to release some growth factors to induce new bone formation. And we shall look at each of the available materials and see whether is the material osteogenic, is it osteoconductive, is it osteoinductive. Now, only a patient's own bone is osteogenic. It is the only bone substitute material that can contain viable cells. Otherwise, If it is from an animal or from another human, then you really don't want to transfer viable cells because of the risk of infection. So let's classify bone materials. Now, bone substitute materials are best looked at, are best classified according to their source. So for instance, an autograft or autologous bone is a patient's own bone. We've said this is the best bone substitute material. It's osteogenic, osteoconductive, osteoinductive, all the three features that we said an ideal bone substitute material should have. The next best option is bone from another human, bone from a donor. Now, it is osteoconductive and osteoinductive, but unfortunately, not osteogenic, because we wouldn't want to run the risk of spread of infection from one individual to another. Now, we can also have bone substitute materials from non-humans, animals, for instance, cows, pigs, and that bone is osteoconductive and osteoinductive. We also have synthetic bone that is only osteoconductive. They are mainly calcium phosphates, yeah? And we shall look at each of them. So let's look at autografts. Well, it is looked at as the gold standard. And when you harvest, you can either harvest a patient's bone either as a block, a veneer, particulate form, bone chips, or bone slurry. So this is a bone block, for instance, harvested from the chin or the retromolar area. So when you harvest, you'll then harvest both the cortical and the cancellous bone. That's a block. A veneer would be, for example, only the cortical portion. Now, how this is used is the bone is fixed using pins on the site that you want to regenerate. And then the gaps that are left are then filled with particulate bone, which can either be the patient's own or actually synthetic. And I will explain how that is done. So fixation pins. Again, that is not my own work, that is borrowed. Now, we can also harvest bone from a patient and put it through a bone mill and end up with particulate bone. We can also harvest bone shavings, and we will see more of this in later slides. So using a back action chisel, you can harvest bone shavings from a source near where you're planning to graft. Now, unfortunately, the patient's own bone autografts have some limitations. And one of them is that they tend to resorb heavily, sometimes up to 60%. And that is a serious drawback because it means you can end up having to regraft a second time because the first graft actually resorbed. Unfortunately, when you harvest bone, there is a donor site and a recipient site, and the donor site can really create some morbidity to the patient. The other big disadvantage is that you never really get enough, again, depending on the size of a defect that you have. So with that, it means that sometimes then you may want to look for other substitute materials, if not the patient's own bone. And therefore, we look at allografts. Like we said, this is processed human bone from cadavers. They're usually donated. It is the next best alternative after the patient's own bone. If you look at it, it's definitely similar to the patient's own bone because it's harvested from a human. It can be presented to you when you buy from your supplier, either as a block, as a ring, and can actually be 3D milled depending on the situation that you're working on. So allografts, like you said, are highly predictable and effective alternatives to the patient's own bone. Like we said, they're osteoconductive and osteoinductive. And the other beautiful thing is, unlike many other bone substitute materials, allografts completely remodel. They will completely become part of the patient. And beyond 6 months, you might actually find no traces of it, which is a good thing. Now, you will commonly find that most of these bone substitute materials are presented to you as demineralized. And the essence of demineralizing bone is so that you can expose the bone morphogenic proteins on the bone substitute. And this effectively increases the osteoinductive potential of any bone substitute. Now, other than humans, we can get bone from cows or pigs. So you'll find xenografts presented in many forms. Commonly, the demineralized form is what we commonly find in the market, and we shall see why that is a good option. Yeah, it comes in various granular sizes and various, grammage, so the choice is really yours. So from Stroman, you have an option of the two. Which one do you prefer? Really, the choice is yours. So we'll say the one on the left is easy to handle. Again, this is all natural bovine bone. So xenografts are mainly presented as demineralized bone. So it is demineralized bovine bone matrix. We've talked about exposing the bone morphogenetic proteins on the surface of the bone substitute material to increase osteoinductive potential. Now, one important feature of xenografts is that they take a very long time to resolve. In fact, they don't exactly resolve. Many years later, you'll still find traces of it, like you can see in that histology slide, that you have new bone, but there are still particles of the xenograft. So they are mainly therefore indicated for situations where you want to regenerate over a long duration of time, huge grafted sites. If you have a huge defect, that will be. And you can see the many porosities to improve the new bone cells that grow in, and therefore you get a huge regenerated outcome. All right, now another option would be alloplastic. Plastic, therefore, would mean synthetic. There are many companies now making all manner of bone substitute materials, and precisely the synthetic option. This is for situations where either the patient is opposed to, maybe for religious reasons, they don't want a certain animal in their body. Some patients will not allow you harvest their own bone. Some will not even imagine that you want to use another person's bone in their body. So this will be a good option. Mainly, alloplastics are hydroxyapatite, 60%, and about 40% tricalcium phosphates. We therefore talk about them being biphasic because there are two phases, the hydroxyapatite phase and the tricalcium phase, and I will explain why the two phases. So the hydroxyapatite phase is mainly osteoconductive, but it does not resolve. Yeah. The tricalcium phosphate phase is also osteoconductive, but resorbs fast and is replaced by the body's cells. The body's, natural bone will grow in where the tricalcium phosphate has resolved. So that is why the two phases are combined. When you want to regenerate over a long time, yet you also want to allow the body have a chance and grow its own cells where bone was lacking. So what you'll find with most companies, they just play around with the ratios of how much hydroxyapatite, how much tricalcium phosphate, depending again on what they want to achieve. So it's important to bear that in mind. Yeah, I saw this patient just this Monday. We had placed this implant in 2017. And can you imagine, I still found some bits of alloplastic bone in there. I'm sure if I took a histology of the bone, I'll find even more. So that's just to show you that that hydroxyapatite phase will actually not resolve. So having understood that every bone substitute material has its advantages and some drawbacks. So what we commonly do is therefore to combine. You take what is good from this option and what is good from this option, and you get a better option. Now, we have seen that autografts, for instance, accelerate new bone formation. That's a good advantage. However, there's limited availability. So you might not find as much bone as you want in grafting, whatever situation you have. We have also seen that they resolve pretty fast. So what do we do? Then it will only make sense that you harvest a bit of the patient's own bone, and then you probably cover it with a slow resorbing substitute. And that will therefore give you a composite graft. So the low substitution filler, for example, a xenograft or an alloplastic option, would therefore protect the underlying autogenous bone from resorption. And that's important. Like we said, many times we are presented with such common cases where, vertically speaking, you have a good amount of bone, but horizontally speaking, you have a problem. So if you take a cone beam CT, look at that. It becomes difficult to manage such a case. And look at that. If you are to attempt to actually place implants, they will be completely outside bone. Good news is, like we said with the Stroman allograft option, you can actually have a 3D printed bone block that you can actually just come and nicely place there and then allow the body to regenerate new bone tissues. Therefore, the importance of cone beam CT cannot be overemphasized. It is critical for you to preempt what situation you're faced with. At this point, I want us to ask ourselves, so when we have a deficiency, do we place an implant and graft at the same time, or do we graft and come back later? I get that question all the time from colleagues. Now, for you to know whether to simultaneously graft and place the implant or not, you need to look at whether a defect is favorable or non-favorable. The top defect, you see you can actually place an implant and you're left with 2 walls. So we normally look at how many walls will you have by the end of placing that implant. So in this case, we have a 2-wall defect, and a 2-wall defect is said to be favorable. Why? The distance that the body's own cells will have to move to bridge that gap is short, compared to the picture at the bottom, where the distance is so long, it takes long for that area to regenerate. So you probably don't want to place an implant simultaneously with the picture at the bottom. So a favorable defect will be one that has many walls, like in that one, at least 2 or more walls. You also are looking at a crest thickness. If you have a ridge whose crest is at least 4 millimeters and more, then this will be a favorable defect. A short distance would mean that you have a shorter period before you have fully regenerated that bone. So in this case, you will therefore do simultaneous guided bone regeneration and place an implant. An unfavorable defect will be where if you place an implant, it will be completely outside what we call the bone envelope. It's outside the alveolar crest. The thickness, for instance, here is less than 4 millimeters. Longer distance to cover, you probably therefore want to do a staged guided bone regeneration procedure where you graft and wait, then you will later come and place your implant. And in my opinion, the minute you internalize these two pictures, then you will not have difficulties deciding whether to place an implant and graft or graft after a period of bone regeneration. So with that in mind, we can therefore conclude that a favorable defect will be where from your planning, you can see that you will correctly position the implant. Since you have available bone, you then would have good primary stability. And you, in the event you end up with a defect, you will have at least 2 walls available. Those walls provide nutrition. They provide new cells, they provide blood, all those things required when you're regenerating a site. So a favorable defect is characterized by those 3 situations. Again, pre-surgical planning is key for you to determine whether those exist. Now, I want to share with you 2 cases of horizontal GBR. And, there we go. So you place your implant and then you can almost see through the bone. If I were to point with my cursor, you can see that dark area there. That's the implant. In this case, this is a small site, and you probably want to ensure that your implant is well covered by bone. So we perforate, we decorticate, create those small holes with a small round so that there is bleeding. By the time you place your bone, and in this case, what we do, we harvest some shavings, yeah, from the nearby site. We lay it right on top of those perforations, you know. Then on top of it, we layer with a xenograft. And remember why we say that's important? The patient's own bone, the shavings will resorb very fast. So to protect them from resorbing very fast, we layer with a slow resorbing material like a xenograft. Then on top of that, we have the membrane. Now, the membrane, as advocated in the GBR principles by Danny Buzan group, is a double layer membrane, yeah, to stabilize and be sure that you have nicely covered your bone substitute material. And of course, on top of all that, you need to ensure that you have tension-free closure. Now, tension-free closure, my apologies for that. Sorry. Yeah, those are the challenges of Zoom. My apologies. So tension-free closure can only be attained if you do a periosteal release incision, and again, maybe select a bone, a barrier membrane that is not too thick, because if you're not able to attain tension-free closure, remember, when the hematoma occurs, all this wound is going to open up, then you have a membrane exposure, you don't want that. So same site, 15 days later, there's almost no trace of what we did. Yeah, so this is a case that is currently, we are waiting for the healing, then we can expose and load the implant. Case number 2 is of a young female doctor, a dentist, undergoing orthodontic treatment. Then they realized, well, we have ended up with a space there, a tooth that was missing, a lateral incisor, and we take a conveam CT, and oh my. So we ask ourselves, can we comfortably place an implant in this case and then graft at the same time? Now, the answer is a no, because we have said we need at least 4 millimeters of crest thickness. In this case, we do not have. So this is one such case where you need to do staged approach. You graft, come back later, then place an implant. So in this case, what we did, we grafted, and 7 months later, that's what we were able to achieve. So this makes it a bit easy for us now. We can now place an implant like we would wish. And sorry, I'm giving my zoom time good. There we go. Oops. Yeah, so you can see in this case, we ended up now regenerating. My apologies. I've never known why Zoom does this. Sorry, there we go. So with that kind of a ridge, at least now you know you can place an implant comfortably at 3.5. We did a neodent implant, and we were able to obtain some good insertion torque, so good primary stability. That's how the case was done. That's how we finally ended up with an implant and a healing collar, because now we can place an implant and do transmucosal healing. And look at that. Even after having grafted for 7 months, we still needed to do a bit of grafting on the day of placement. So you can see the picture on the top left. And then 4 months later, with a healing collar in place, that looks as is. Down here, after now the case is complete, you can see how much bone is on the backhoe of your implant. That is what we desire. And that's the completed case. So the point is this: when you know whether to place simultaneously as you graft, that to me is critical. Otherwise, you will end up with complications that would have been avoided by proper planning. Now, like I said, I'm not going to dwell a lot on vertical regeneration, but I'll just show you one case here of a patient who required implants, and what was of importance to us was the upper jaw. You can see the amount of pneumatization, and look at that. So on the left, we could dodge with short implants, but on the right, that's not possible. So what do we do? Sorry. Give me a minute. My keynote is lagging, but as it opens, yeah. So on the right, we decided to do a sinus lift because it was not possible to even place a short implant. We would have ended up with the sinus, so we opened up as indicated. And then once the sinus had been lifted, we filled that with an appropriate bone material. And in this case, we want to wait for healing, at least 6 months. So what bone material will I use in this case? I could use a patient's own bone, but it will resorb in a very short time. I doubt I'll have regenerated the amount of bone I need. And I mean, you've seen how much defect we have. So in this case, we chose an appropriate bone material, which I'll show you. Then we use the short implant as indicated. Then the 2 implants in place and the graft material exactly where we would want it to be. Sorry, this should be the last hanging slide. Good. So as you saw initially, we removed a bone block. So now we are putting it back. And we have it back exactly where it would be. We have decided to use a low substitution material and also a membrane that will be there as long as the bone is there. So again, a resorbable membrane that will not resorb sooner than it would take to regenerate this case. So that's the bone material we used. It's a xenograft material, yeah, a mix of bovine and porcine, so that it closely resembles the human bone. Very nice, easy to handle, like you can see in a syringe. So once you wet the material, you can nicely syringe it into the sinus. Since that is xenograft, it will take a long time or will never resolve, then we also need a membrane that will be appropriate for this case. And for this particular case, we use a JSON membrane, which, as I mentioned, takes a long time to resolve, about 6 months. So it will be appropriate for such a case. So it's important that you always remember what material you are using, therefore what membrane should you use. What is the clinical situation? That is really how you should arrive at an option for a bone substitute material. So that's the field case with the sinus, elevated and material field. This case is now about 5 months, so I have about a month and a half or so. Then we will do exposure of the upper jaw. And I'll be happy to share with you the same case at some time when UDA invites me again. Now, having said all those things, it's important that I highlight some other ways in which you can improve the outcome of your regeneration. And in particular here, we talk about tissue engineering. This is just modifying the body's tissues and cells to your advantage. So for instance, these are commercially available platelet-derived growth factors, yeah? Recombinant human, PDGF. What clinicians now do, for instance, I like following Danny Buzan group, they infuse the bone substitute material with these commercially available growth factors, and definitely it improves the healing outcome. I'm sure you're familiar with this, yeah, a PRF machine where we derive a platelet-rich fibrin, same concept. You want to make a sticky bone, yeah, you want to infuse your bone with IPRF, or you just mix it with APRF, and really you get a good regenerative outcome. I must, however, point that sometimes I've had people say that they just use PRF without the need for bone, without the need for membrane. I think that is not exactly supported by science. From what I have read, what I have experienced, it's important that you remember what we talked about, bone and membrane. These others are really to augment and improve the outcome that you get. Just a highlight, those platelet-derived growth factors, many times when there is injury, they're usually the first natural signals to that site. And they help by attracting and multiply bone-forming cells. They upregulate new blood vessels. Like we said, we want new bone cells and new blood vessels because your new bone needs to be well vascularized. There are also studies to show that some people are deficient on these growth factors, and therefore infusing the bone substitute material with these commercially available growth factors then can be justified. So it's something important to look at. There is now enough literature you can read. I'm yet to use the commercially available ones, but I use the PRF derivatives, which I believe Dr. Tom and Pan Dental Surgery have taught you extensively. Now, one last point will be bone conditioned media. Again, Danny Buzan group have now demonstrated the molecular mechanism underlying a favorable outcome in GBR by using bone conditioned media. Here, they advocate that bone shavings are harvested from the patient as you do the implant placement. You also harvest some blood within 40 minutes. You mix those two and you leave them for about 40 minutes. By then you will be placing your implant. And what they have demonstrated is harvesting those shavings within those 40 minutes improves your regenerative outcome. So they advocate that if you are still to use the xenograft or whatever else, coat that bone substitute material with this bone conditioned medium, and also coat your membrane with the same. You get a better treatment outcome. And the science behind it is that the stimulatory and dose-dependent effect of transforming growth factors and bone morphogenetic proteins that induce osteoblast differentiation. So this is a huge advantage, and like I'll demonstrate to you, it's actually a very easy procedure. So I'm going to share with you a case I did about 2 weeks ago. The patient comes, so we open up the site and we harvest blood from the same site. We use our back action chisel and we harvest bone shavings as indicated. And those are the bone shavings. So these two, the blood and the bone shavings, are actually what will give us our bone conditioned media. And sorry. So give it time, hanging a bit. Yeah, so as it is opening, you can clearly see that these are readily available materials, within the same patient's mouth. And so with those bone shavings and the blood we mix, as you can see, the bone conditioned medium is now ready after immediately after harvesting. So we add our xenograft into that mix, and just make sure that we mix up everything. We also coat the membrane, and you can see one other advantage and something that you need to look out for whenever you're choosing a bone substitute material is of handling. Look at that. The bone is not, pouring all over. I've used all manner of bone substitute materials, and some are very frustrating because you would actually need a very special device to carry that bone from the container to the patient's mouth. But with this bone conditioned medium and a xenograft from Stroman, easy to handle, and you can see we introduce it. I don't know whether you're able to see some perforations there. Like we say, that should be standard practice. Then here we have our double layered membrane as advocated by Danny Buza and group. This case is only 2 weeks, but from the review this week, we are doing well. Of course, I wouldn't assess the effect of bone condition medium at this stage, but by simply following those principles, we are positive. Like we have showed in other cases, this is standard practice for us, and we are now able to almost with certainty know what to expect. Yeah. Great. Now, I cannot finish this presentation without highlighting the use or the lack of use of antibiotics with guided bone regeneration. This is a very common question. Should I medicate? Should I not medicate? What does the evidence say? Now, whether to prescribe antibiotics or not really depends on many factors, but the most important is the patient's medical status. Assuming that this patient that you're working on has no other medical conditions, because those need to be taken care of before the bone grafting procedure, the extent of the flap that you elevate really determines whether to prescribe or not to prescribe antibiotics. So, for a small flap like that, evidence shows that you can actually prescribe amoxiclav 2 hours prior to surgery, and you should be fine. The outcome will be good, and there is minimal risk of an infection in that site. In instances where you have a huge site that you are working on, evidence supports the use of systemic antibiotics for up to 7 days. So whether to prescribe or not to prescribe antibiotics must be informed by the medical status of the patient and the risk of hematoma formation. Look, the picture to the left, the risk of hematoma formation is not as much as is compared to the picture on the right. So on the right, for sure, systemic antibiotics for 5 to 7 days would be justifiable because you know the whole debate about misuse of antibiotics. So it's important for you to bear that in mind. So what are the keys to predictable outcomes with GBR? One, we've talked about a composite graft, and we cannot overemphasize that synergy. Autografts, very good with giving you that boost of cells occupying an area where you want to regenerate, but again, they are slow resorbing, so you probably want to cover them with a slow substitution material like a xenograft. Tension-free closure, I cannot overemphasize the need for periosteal release incisions to ensure that you do not suture under tension because that wound is likely to open up. Interrupted sutures and horizontal mattress, that I'm sure is well understood. The need for excellent oral hygiene by the patient at home cannot be overemphasized. It's important that for grafted cases, closely monitor those cases, to ensure that in case anything is coming up, you're able to attend to it. It is advisable to avoid anything that is going to compress our grafted site, and in this case, dentures. But if you must use dentures, like we did in this case, then you need to ensure that you relieve so that your denture does not have a buccal flange or does not squash your grafted site. It's important. If you can avoid. The problem will be, of course, supra-eruption of the opposing teeth, and here it will be difficult to have a Maryland. So it's important to have that in mind. Another important feature will be sometimes you might want to stabilize your membrane by using tack pins as indicated. It really helps because remember, it's like a fracture. Healing of a grafted site is like healing of a bone fracture. If there are movements, then you'll have malunion. If there are movements, then you will not attain the regenerative outcome you desire. So sometimes you will consider using tack pins. So what are the possible causes of failure of guided bone regeneration? Infection. For sure, that's a killer. Inadequate blood supply, and mainly this is due to poor flap design. When you have a flap with a very narrow base, you're cutting off blood supply, and for sure it will die off, and the whole exercise is, it will be an exercise in futility. Mechanical instability. For huge grafted sites, consider either using a non-resorbable membrane. If you use resorbable membranes, then you need to have tack pins to ensure that there are no movements. Use a double layer membrane if you're going to use a resorbable membrane to ensure that you have some mechanical stability. Because remember what we said, the tissues above can actually pose as a threat to your regenerative outcome. Oversized defects that were poorly planned for will certainly not come out as you wish. It's important to bear in mind the size of a defect and therefore ask yourself, is it favorable or non-favorable? So should I go simultaneous or should I delay, graft, then later come back and place the implant? Colonization by competing tissues. We've said fibroblast and epithelium they grow faster. Yeah, they grow faster than bone and therefore can easily take up the bit that you had secluded where you wanted to regenerate bone. They can actually all go occupy there, and then, that's not what you want. So bear that in mind. Therefore, as you choose your membranes, ensure that the membrane will last as long as the bone below is going to be there and for regeneration to be successful. Because if the membrane resorbs way earlier than the bone below it, then the soft tissues will just go and take up the space meant for bone regeneration. Yeah, you'll have fibrous encapsulation of your bone substitute material. So that's critical. So to sum it all, if you were to forget all that we said, remember that pre-surgical analysis is a key to a successful GBR procedure. Because unless you know what to anticipate, unless you know what to find when you open up, then you will always have complaints. I get a lot of complaints from colleagues. You know, I did a bone graft, but I find I haven't achieved what I wanted. Of course, planning was poor. So it's important to have non-invasive analysis of a surgical site. We said a crest width, you know, of greater than 4 millimeters, or at least a situation where if you place your implant, you have two walls or more. That's a favorable defect, and that is a situation where you would place an implant and simultaneously graft. If those two are not achievable, then you'll need to graft and come back later to place your implant. That's important. And lastly, the clinical situation that you're faced with should really dictate what biomaterials you shall combine. And if you understand the various properties of biomaterials, then you know how to handle any clinical situation. Like we said, remember resorption. How long does a material resorb? How big is a defect? Therefore, how long should a material be there for me to regenerate this kind of a defect? For instance, a small defect, then you can just have the patient's own cells in a short time. That bridge will have been covered and you'll have regenerated enough. But if it's a huge regeneration area, then you need a material that does not resorb very fast, because then that huge defect will not be managed as you would wish. So it's important. The properties of biomaterials and the clinical situation, in my opinion, are the key determinants to the selection of biomaterials that you shall arrive at. And with that, my good friends, I want to thank you, and may God protect you. I am available whenever you need us to have a chat. I have many friends in Uganda, so it's really a pleasure.
Thank you, Dr. Gakonyo, for the presentation. Thank you very much. We have a couple of questions. The first question is from Dr. Mabari Muhammad, and it goes, what is the impact of bone graft preparation on osteogenicity?
So, impact of bone preparation, you said?
Yeah, what's the impact of bone graft preparation on osteogenicity?
Osteogenicity. So, should I take that?
Let me read all the questions so that you can answer them. I think so. Yeah, the second question is from Dr. Peter Karisula. Comment about barrier by bulk concept by Karl Marx.
I didn't get that.
Comment about barrier by bulk concept by Karl Marx. Then the third question is from Dr. Umar Kizito. He says, if I had less than 2 millimeters of buccal bone, are there follow-up studies for or against treatments with and those with GBR?
Sorry, I think you're fast on that one. I need to note that.
Okay.
Yeah, the last question. Let me just quickly.
Okay. The last question is from Dr. Omar Kizito. It says, if I had less than 2 millimeters of buccal bone,
yeah,
are there follow-up studies for or against treatments with and those with GBR.
Are there what? 2 millimeters defect?
Are there follow-up studies for or against treatments with and those with GBR? Follow-up studies for or against treatments with and those with GBR.
All right. I will attempt to answer the first and the last question. So I think the first one was by Dr. Mbabali.
Yeah.
And if I got the question, his question is on the impact of bone preparation on osteogenicity.
Yes.
All right. So what I at one stage mentioned is osteogenicity is availability of viable bone material. Rather, viable cells, a viable osteoblast. Yeah. I were just to escape this. So if we are talking about viable cells, it will also mean that if you take way too long, yeah, and that's, in my opinion, will be why the Danny Buza group recommends about 40 minutes. If you take too long, then I doubt the cells will still be viable. Yeah, if we were to come back to this slide here, yes. So a viable osteoblast, yeah, and whatever other precursor cells. So the time it takes to prepare, in my opinion, would affect the viability of those cells, and also the treatment that the bone goes through. I do not know what else one may want to mix the harvested bone with, but since we are talking about viable cells, then they will be subject to the manipulations that you subject your harvested bone to, if I got his question right. Now, the Dr. Kizito question on if I understood, are there any follow-up studies on doing GBR or not doing GBR at all when you have less than 2 millimeters defect? Is that the question? Doctor, did I get the question right?
Yes, sir.
Is it possible to allow Dr. Kizito to actually ask the question if he can unmute himself? Yeah.
It's okay, sir. It's okay. Dr. Kizito, you can ask your question.
I think you actually got the question. I was just wondering, if I have less than 2 millimeters, maybe 1 or less, are there studies that have shown the outcome of the implants that have been placed in less than 2 millimeters without GBR, and those ones done with GBR, so that we can compare and see as a clinical application, are we doing it or not when we have such scenarios? But that's exactly, you put my question right when you said it out earlier.
Yeah, I could refer you to the work by Bob Schenk and Danny Buza. For them to actually recommend the 4 millimeters as the cutoff point, it was actually advised by many times what is commonly available in the market. We are looking at implants of about 3 to 4 millimeters would be, one of the narrowest diameters available for implants. Of course, with very tiny implants, you would. But again, if you're talking about 2 millimeters only of bone, yet we said we require 1 to 2 millimeters. It's actually now a strong 2 millimeters of bone all around your implant. If you were to prepare that kind of a bone, if you were to prepare an osteotomy in that kind of, a thin ridge, then I'm sure you will end up with way less than 1 millimeter or 1 millimeter of bone on either side of your implant. So for sure, this will be a disaster. Yeah, but I could share with you the papers by Buzan Group. Yeah.
Okay, doctor.
Yeah, sorry. The third question, I'm not sure I understood it, but he was asking about a technique by Carl Misch. Yeah, and I wouldn't really want to comment on this. I'm not experienced with this at all. I have only seen it in passing. But I must report that mine is a biased opinion because I mainly conform to the Buza approach with guided bone regeneration. So for that, I wouldn't want to give an opinion on.
All right. Thank you very much, doctor. We have more questions from Dr. Mbabali. Dr. Mbabali, welcome.
Thank you. I'm on. Thank you, Dr. Joseph, for the presentation. It was wonderful. On the first question, I just wanted a clarification again, because most people tend to make that mistake, thinking that an autograft is likely to give you osteogenicity. But many times, in the process of harvesting, processing, the time taken, and even how you place an autograft, the chances are the osteoblasts with which you've carried are gone. So the best you can get from it is the proteins, and that will give you induction. And that induction is good to attract the cytokines that are other matrix metalloproteinases, other matrix proteins, and the matrix proteins, so that it can really help in, and it also reduces the rejection by the body, since it's the same material, just relocated from another point. But the cellularity is highly questionable, because the process of processing that bone, whether you bring a block, whether you bring or you crush it in a pestle, whether you centrifuge it, whatever you do, the process usually tends to kill the cells. But at least it maintains the proteins, which are very, very critical in osteoinductivity. Of course, plus the function of conduction, being that it is bone, it is hard, it's a scaffold. That's what I wanted to clarify, so that people don't say that when I have an autograft, I'm assured of this. Still, the processes must be respected. And as you've said, even in the process of harvesting, in the process of preparing an osteotome, or the place where you're going to put the implant, it is important that you keep removing this bone that you've drilled out from the bar and keep it in a safe place, so that later you can use that bone, mix it with an allograft or a xenograft, and then later you can use it for grafting. And generally, as a principle, like it or not, most of the anterior implants, especially in the upper jaw, will require grafting with or without exposure of the threads, because many times there is that duration that takes place between the time someone loses the bone and the time someone comes, and also other anatomical features around that area, especially that curve that we usually see. It is heavily augmented by loss of teeth, such that by the time you're placing your implant, you already have that depression. And if you really don't take care of that depression, it is a problem. And also for those who do guided surgery in anterior implants, the issue is the anatomy of that bone with that C shape or that base shape usually gives an impression that you have enough cortical bone you have enough bone thickness at the level of the crest, but you're still not sure whether by the time you go into the bone or with whichever direction of the surgical guide you have, you may sometimes end up having areas where you're very, very close to the cortical bone. So usually my best recommendation is that when you're placing implants in anterior region, always go with open method, open surgery method, so that you can identify any areas of little bone or exposure so that you can graft them comfortably. Thank you.
Thank you very much, Dr. Mbabali, for the clarification. Dr. Joseph, there's another question from Dr. Mplume Davis.
Yes.
In harvesting blood to mix with the bone substitute material, does it matter the source or site of collection?
No, it does not really matter because it's just the patient's blood. But I would imagine that instead of creating an extra surgical site, you would harvest from, the same area where you have made your incision. It's better for the patient and also for you. It saves you time.
Okay. People with any more questions?
Yes, I have seen a question in the chat. There's a question on how, kindly comment on the surfaces of the membrane in terms of which surfaces should face the graft and which one should face the soft tissue. I'm sure Mbabali here, yeah, I get his question. Now, every membrane has one rough surface and a smooth surface, if you look at it carefully. So the rough surface should face the bone, while the smooth surface should face the soft tissues. There is another person, there's a doctor here named Huntington. Kalmish mentions that with soft tissue can grow to a certain depth. So which cases of thicker graft could be as barrier membrane, meaning overgraft with primary closure would be okay with membrane. That's the, well, if I follow, they mean if you have a thick soft tissue above, I don't know whether they mean whether to ask, do you really need a membrane? From the Buza group, yes, you need a membrane. Doesn't matter the thickness of the soft tissues above. I'm not sure I got the question, but that would be my thinking that yes, you need a membrane to protect, to seclude the area and only allow occupation by bone-forming cells.
Okay.
Dr. Gakonyo, I have another comment.
Yep.
I would like.
Yes,
I have another comment. This is Dr. Mbabali.
Yeah.
In one of the cases where you showed us, and there was a darker gray shade, showing that the cortical bone remaining is little.
Yes.
Assuming you did not do, or you did not release the periosteum from the connective tissue, and all you needed is a thin bone graft, wouldn't the periosteal layer on the connective tissue side act as a barrier membrane from stopping the other soft connective tissue crossing? Would you still want to put a membrane there? Thank you.
Well, I get your point that if we left the periosteum intact, would we still need a membrane below? For such a small site, it really depends. But I would not have bone and allow my periosteum to go over, because sometimes when just elevating it, I'm so sure I at some point probably pinched it. Because I do not really think that you can really elevate such a site without damage to the periosteum. But if it's very conservative, say in an immediate place situation where you have a thick bone, you've placed your implant, you push in your material below. I see lots of clinicians now. I was just watching a presentation yesterday by Neodent, and yeah, the only thing they do is they do a mucoderm to increase the thickness of the soft tissue, but not really to protect the bone, because it's a small portion of the bone that will really be exposed to the soft tissues. So in my opinion, that I think is a clinical decision that you have to make. If it's a very small area, maybe not. If you have damaged or suspect you could have touched the periosteum, then that will pose a risk to your grafted side. So a clinical decision indeed.
Yes, Doc, there's another question from Dr. Nono's Juliet. When harvesting the bone, do we eliminate the periosteal layer?
Oh yes. When you're harvesting the bone shavings, you have to do a full thickness flap. Then you still have to sometimes use any scoring object, could even be a hand scaler, just to make sure that there are no remnants of soft tissue on the bone surface as you harvest your bone shavings. So yes, eliminate the periosteal layer.
Okay, I think there are no more questions. Let me take this opportunity to thank Dr. Joseph Gakonyo for the presentation. Thank you very much. We really appreciate as UDA. Thanks members for attendance. If there's nothing more, have a good evening.
Yeah, thank you very much. We'll see you another time. Have a great weekend. Thank you.
All right. Thank you very much.